From the RSNA, I'm Dr. Jana Ivanice, and this is Radiology Imaging Cancer. We are back in your feed with a special podcast episode where we continue to focus patient advocacy in cancer imaging. If you're interested in this topic, I highly recommend our previous episode where Dr. Adeline Bircher interviewed Teresa Roebuck-Spancer, a clinical neuropsychologist and patient advocate working on bringing awareness to glioblastoma. 2 episodes ago, Dr. Eja Ndom shared his perspective as a neurosurgeon and researcher working with patient advocacy groups. There is also a recent interview I highly recommend, published in Radiology Imaging Cancer, where Dr. Gary Luker spoke with Erica Loshko, a breast cancer survivor, about her experience. As radiologists, we play a key role in cancer diagnosis, treatment planning, and response assessment. And one of the most important things about our job is to always remember that there is a human being behind every radiograph, CT, MR, and PET exam we read. To gain more insight into the patient perspective, our trainee editorial board member, Dr. Ricky Safjani, spoke with Paul, a head and neck cancer survivor who was treated at the University of California, Los Angeles Medical Center, where Ricky is a radiation oncology resident. Ricky also spoke with Liz Morasso, a licensed social worker who runs support groups for cancer patients at UCLA, about her experiences as a social worker and patient advocate guiding cancer patients and their families through this difficult journey. Thank you all for joining, and without further ado, I'll hand it over to Dr. Ricky Safjani for his interview.
Thank you, everybody, for joining this podcast from RSNA's Radiology Imaging Cancer. My name is Ricky Safjani. I'm a resident at UCLA in radiation oncology. And today I have the honor of interviewing someone I know dearly, Liz Morasso, who's our licensed clinical social worker in the department, and also Paul Soshek, who is a patient and survivor of head and neck cancer who's undergone radiation therapy. And today we want to highlight sort of the role that the patient has, the person behind the imaging and their perspective, and also Liz's role in helping patients navigate through the complexities of going through treatment. And so, Paul, maybe we'll start with you if you want to just quickly introduce yourself and talk to us a little bit about your journey as it began.
Certainly, and thank you for this opportunity. I come from a business where you work crazy hours and your health is not always paramount, and I smoked a lot and I drank a lot, and I want to say it was in 2011, I had a sore throat that wouldn't go away. Anyway, a few years later, problems surfaced again, almost identical. Dr. Chetri scoped me, whatever, took a biopsy, and then a few days later, I got that call. And it's funny, I just throw this in there, as I work in motion pictures, and we've all seen that scene where somebody gets the call, gets the news, gets the thing. And it was a really strange, actually having it happen to me. And the time, whenever showed up, it was a very minor tumor. According to the biopsy, it was I think it was a T1 at the time. But before I even went to meet with the doctor with the results of the tumor board, I went to the UCLA Head and Neck Cancer Support Group. I didn't know what my treatment plan was at the time. I didn't know about it or anything. And that, to me, was maybe one of the smartest life decisions I ever made. And I owe that to my partner, because I'm not big on let's go talk about our feelings. And she said, you find out as much as you can, you meet with people, you get as many opinions as you're comfortable with. I realized then and there that really I'm going to have to be my own warrior. I knew better than to go down the internet rabbit hole. And anyway, so the push was from the people from the tumor panel. Their results were chemo and radiation. And I was leaning towards surgery. Meanwhile, the second opinion doctor, and he said, after looking at the data, looking at me, he said he thought I was a kind of an ideal candidate for robotic surgery. And it was a longer procedure than thought. And ostensibly, the way the tumor was behaving, it wasn't a T1, it was a T4, and it was incredibly aggressive. But here I am now, clean, over 5-6 years out, and that's all good. And in a weird way, I think there's a lot of positive stuff that's come out of this. I mean, that's kind of how I frame it, and I think that's kind of how you have to frame it.
Yeah, that's a very interesting point. That might be a good segue to introduce Liz a little bit here. So Liz Morasso, who's our licensed clinical social worker in our department of radiation oncology. Liz, do you want to tell us a little bit about yourself and the social group and support groups that you've helped build?
Sure. So my name is Liz, and as Ricky said, I'm the licensed clinical social worker in radiation oncology at UCLA. And my job consists of a lot of different pieces. So I kind of help and provide support around everything from logistic concerns and access. So things like transportation to the hospital and daily appointments, housing for treatment for patients that are coming from far away, maybe out of state. This comes up a lot for patients that are on specific studies or trials. That's often where that kind of scenario comes up. And then things like making sure that patients are able to navigate any kind of employer medical leave. All of these things might seem kind of like really just concrete checkboxes, but those logistic and more concrete pieces are what keep our patients motivated and able to have access and actually come to their appointments, feel motivated to appointments, be able to focus on those appointments as opposed to other stressors in their life that might have been affected by their cancer. So that logistic and tangible piece is part of my role. Also, just like kind of general routine check-ins on how our patients are doing. In radiation, I'm so grateful because our patients are typically here, every day for about 6 weeks. And so what I get to do is focus on more short-term interventions for our patients and families, helping them cope with their diagnosis, help them cope with their treatment, and then work on setting up a really realistic plan, or as realistic as possible, I guess is more the right way to frame it, following completion of treatment. So that means that I can provide one-on-one psychotherapy to patients and their families. And it's not just their families. Sometimes we see friends or maybe acquaintances that patients have that are their support system. So my job is to make sure that the people that are involved in the lives of our patients are also able to provide the right support to them, again, to really optimize that treatment plan and optimize the outcome.
Yeah, thanks, Liz. And I think for patients, having somebody like Liz means the difference of being able to get treatment versus not, right? Because if you can't make it to your 35 radiation treatment appointments, it's not going to be feasible. So it's incredibly important. We're really thankful to have you in our department. So I think it's great. Do you want to touch a little bit about the social groups and support groups that Paul was referring to?
Sure. So I started in this department around 6 years ago. And when I started, I quickly learned about the head and neck cancer support group that had been running and had been ran by the social workers who preceded me. And I was told that this is a really stable group. They've already been meeting for a few years. There's kind of this consistent group of people, but we're also really trying to get new patients involved. So we have patients kind of similar to what Paul's experience was, where they're just diagnosed. They might not even have a treatment plan yet, or they're considering treatment plans or even institutions. And then we have patients 17, 18 years out of treatment and everything in between. So the group is an amazing place where patients can come and families are welcome to and get validation of their experience, get normalization of their experience. So maybe that wasn't something that was discussed more formally, but coming as part of the group, everybody kind of has their little tricks and things that helped them get through treatment. And the ability to not only obtain that information from very trusted sources, as in patients that have already experienced this before, but maybe also share things that were helpful for them. I think that it's a really incredible experience for patients to finally feel as though they have somebody that's neutral to be able to not only share their experiences with and feel validated around, but also their feelings, and thoughts, and know that the people that they're sharing this with know what they mean. For example, when they're saying, I'm so tired, tired means one thing for someone without a health issue. They might hear from a family or friend like, okay, why don't you go take a nap? Well, that's not the kind of tired that they're referring to. And so knowing as a patient that you can use language like that you can make statements about your cancer journey, and the group is going to really feel that and understand that, have this unique sense of empathy around that. I think that is really what's made our group really special.
Yeah, that's really great. How many people typically show up to these meetings, and how often do they happen?
Yeah, so right now we're doing it once a month. When we were doing them in person, we had anywhere from maybe 5, and then I think one time we had like 25 people, and everything in between. So sometimes it's around 10. And that's a really good group number for me as a clinician. I think that 10 to 15 people is really awesome energy, is great to facilitate that number of people, even if they're not physically attending groups. And right now we're doing them over Zoom with the hope that we can continue that after COVID, to allow for some patients who really like that in-person engagement to be able to come in person, but also those that maybe are going through treatment that it makes it difficult to come to group, or they live far away, or something is keeping them from coming in person. We hope to keep that hybrid model once we get back to some kind of normalcy after COVID.
Yeah, that's fantastic. It's really nice to see that at least a silver lining of the effects of the pandemic, enabling maybe more people to connect and meet. So that's fantastic. Paul, thank you for your fabulous introduction into this. So you talked us through your initial reactions and your initial nasolaryngoscopy. And then most patients really, after that, after the biopsy on the scope, will have some type of imaging done. And for head and neck, that's typically a CAT scan, a PET, an MRI, or some combination of all. Can you talk us through, what it was like when you first went through that imaging, and what it was like when you kind of first either saw the report or walked through it?
I have to say that whole period is just a blur. Probably the reason that's a blur is because you're oversaturated between appointments, between trying to make sure you're doing this right.
So you had your surgery. So the next step is usually what we call a CT simulation, where patients come in and lie in the position that they're going to be treated in. And this involves just lying still and getting a CT scan. But talk us a little bit about that.
I am kind of claustrophobic, and I don't know what it was. I was just in my head, there was that thing where you're just saying to yourself, this is what you got to do to get through it. So just deal with it. And for whatever reason, between the tubes and the swelling and the drainage and blah, 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 but my brain just went cartwheeling, and I was like, oh my God, I'm going to die. I'm going to suffocate.
So yeah, I mean, the mask itself is just a setup, but then you're coming in, most patients are coming in every day, Monday through Friday, for 7 weeks for 35 treatments, right? So maybe I'll ask Liz a little bit. Tell us about, what do patients experience that? And then Paul, you can, chime in with your experiences as well.
So in my experience, what patients and families share with me, in the beginning, it still seems so incredibly overwhelming. They're still reeling from their tumor board, from their surgery, from a biopsy, from what they're still coping with, whatever led them to radiation. And oftentimes there was not the appropriate amount of time for any human being to be able to process that effectively before they have to start coming in every day. So in the first few weeks, I find that though patients often with head and neck cancer have less side effects in the beginning of their treatment, they're more overwhelmed. They and their families are more overwhelmed emotionally and logistically, trying to figure out who their specialists are, what are their appointments, what is their routine going to look like, what do the finances look like, what do some of those logistic concerns look like. But I think in a good center, the way that we build relationships to our patients, the way that we help subdue some of that anxiety and address their concerns, but some of the access issues and barriers and more logistical challenges are what I see more in the beginning. So it's, well, how am I going to inform my employer in a way that is not going to affect my job and my benefits? How am I going to get protection of those things? How am I going to have any kind of financial benefit during my treatment? Who's going to take care of my children? And so, I feel like those first few weeks are so incredibly tough to get past each day because there's so much that's not part of a routine yet, or so much that's not tied in a bow yet. That sometimes when we get to the end of treatment, that's when maybe there's a little bit more room to start exploring, patients' emotional health and well-being, and, get them connected with the support group. And despite our best efforts to do that early, it also is our job to assess whether a patient and family is ready for that, whether it's appropriate, and at what time, this would be best for a patient family to connect with that kind of support. So there's a lot of different pieces that are up in the air at any given time throughout the whole treatment trajectory from pre-diagnosis into survivorship.
We're incredibly grateful in general as a teaching hospital that we have residents like myself have the opportunity to learn from willing patients.
Work with smart asses like me.
That's right. But Paul, thank you for that, and thank you, Liz, for all the information. Maybe the last question, Paul, before you head off, and thank you again for all of your time, is if you, with all of your experiences in the process, if you had to share something with someone who's about to embark on the same, going through diagnosis and the treatments and everything that you've gone through, what kind of advice or
Well, one thing I learned is that you need to take care of yourself, and you really owe it to yourself to try and explore the resources that are out there, because they are out there. And the main thing is that it's going to be okay. It may not be perfect, but it's going to be okay, and you will get through it. But as far as taking time, knowing to slow down, knowing to cherish things a bit more, knowing to cherish that, gosh, I'm getting some of my taste buds back. Some people don't get any back. I'm getting some back.
You're not alone, that there are support systems, and there's many people who've gone through it and can walk you through it. And Liz, I want to give you a chance maybe to hear your final thought from the clinic.
Sure. I think to my radiology colleagues, I just ask that you see the person and not just the image. And you might not know where that person works. Is that person in a relationship? What does their support system look like? There's all these pieces that you don't know. However, what we do know is that they're incredibly vulnerable no matter what. And it is a really humanizing thing to reflect on. And I think a really great way to reset in between readings is when you bring that image up, acknowledging this is a vulnerable person, and that's what I know. And I'm going to do my best to help get this person the best reading, the best assessment and impression that's communicated effectively to the team so that they can carry that torch on. And be able to sit with that you had something to do with that was so crucial, and that you are helping optimize our patient outcomes. And you're doing that by being, one, a human being first, and also have this incredible skill set to be able to read these images and have this knowledge and be able to make connections that so many people depend on to live their best. So I think if we can always put that behind our intention and behind the work that we're doing that might not seem patient-centered or patient-facing or person-centered, however we want to view it, I think it's just a good reminder and maybe a good practice to have maybe in between images, as I mentioned, or in between cases, taking a deep breath and opening that image up and reminding yourself of the power of your work, of the uniqueness of your work, and by the effect that your work is having on a patient, a family, and a community's life. And ask questions. If there's things you want to know, if it's within a scope of things that can be shared with you, if you think that that's helpful for you to know, ask the team. You can ask about maybe what a treatment outcome was, if it was something that meant something to you. We don't have to push our human side away in the vein of science or for science. We don't have to push the human away for science. It's science and humans, science and humanity, science and empathy and compassion and answers and relief, and ultimately saving people's lives and or helping patients live the best life and being able to make the most informed decisions, which is ultimately, I know my goal, and I know at UCLA, that's our goal, to help patients be able to make those decisions for themselves.
Yeah, that was really beautifully said. Well, thank you again very much, Liz Morasso, who's a social worker at UCLA in our Department of Radiation Oncology, and Paul, who's a survivor of head and neck cancer and a survivor of radiation therapy. Thank you both for this session, and we really will benefit a lot in terms of helping future patients and helping patients get through the treatment. So thank you.
This concludes today's episode. Thanks to Dr. Ricky Safjani for shining a light on this very important and complex topic. I was very moved by Paul and Liz sharing their experience. What really stuck with me was when Liz said, "I ask that you see the person and not just the image." Truly words to live by as a radiologist. Thank you all very much for listening. I hope that you enjoyed this episode. We would love your feedback. Please subscribe on Apple Podcasts or wherever you're listening right now and give us a rating to help more people discover the show. We also love to hear from you on social media, especially Twitter. I'm Dr. Jana Ivanice, and this is Radiology Imaging Cancer. See you next month.